Hi, good afternoon, everyone, and welcome to today's UNM Psychiatry and Behavioral Health Sciences Grand Rounds. My name is Dr. Marquette Rose, and I'm one of the reproductive psychiatrists here at the University of New Mexico. I'm excited to be back again to introduce Dr. Samira Khalil, who brings to us her expertise on the management of perinatal psychiatric emergencies. Dr. Samira Khalil is a board-certified psychiatrist who's currently in her Reproductive Psychiatry Fellowship. She specializes in evidence-based treatment of mental health disorders during the perinatal period and of patients with mental health disorders and crises. She has a special interest in diversity, equity, inclusion, and social justice and how this affects her patient population. Dr. Khalil is committed to the state of New Mexico and is passionate about providing care to patients with mental health disorders, especially women with mental health disorders in the perinatal period. She currently spends half of her time pursuing the fellowship in reproductive psychiatry and the other half as an attending psychiatric emergency provider. She also is active with residents in the department with the creation of learning communities, houses, and creation and implementation of the DEIJ curriculum, both within the department and through graduate medical education. Dr. Khalil, thank you so much for taking the time to present for us today. I'll pass the mic to you.
Thank you very much, and thank you for that introduction. Let me go ahead and see if I can share my screen correctly. All right. Sorry, 1 second. All right, do you see the proper?
Yes, it looks right.
Okay, cool, thank you. All right, so I will be talking about perinatal psychiatric emergencies today. I have nothing to disclose. Here are our learning objectives for today. Be able to recognize postpartum psychosis, be able to assess for safety of perinatal patients with a psychiatric emergency, know how to direct care for reproductive psychiatry patients, and be able to list the top causes of maternal death in the United States. A note on language. In order to be inclusive of all individuals who can become pregnant, I will be using the term pregnant or postpartum individual. However, the research that is present on this population is typically based on cisgender females. So when I'm referring to research and statistics, I will say women, but when I'm referring to clinical encounters and diagnostics, I will say individual. So the prenatal period is a high risk time. Pregnant women with psychiatric illnesses have higher rates of adverse pregnancy outcomes. This includes things like preeclampsia, needing a C-section, having gestational diabetes. About 1 in 13 women experience a new onset of major depressive episode during pregnancy. Discontinuation of antidepressants in pregnant women is with a history of MDD accounts for 60 to 70% of mood relapse episodes. Discontinuation of mood stabilizers during pregnancy is associated with 80 to 100%. Individuals with a history of bipolar will have a relapse. For comparison, from that 80 to 100%, women who are continued on their bipolar medications, the risk of mood episode decreases down to 29 to 37%. Antenatal anxiety disorders of all subtypes are diagnosed in about 15% of women during pregnancy. I would like to start with a case. AL is a 24-year-old G2P0, assigned female at birth, uses she, her pronouns, transferred from the ED to PES with concerns for delusions. She believes that she is pregnant with a parasite. On exam, she tells you that she needs to extract the parasite in order to save herself. She has not tried to do so, but has considered ways, including using a knife to cut it out. Labs are noteworthy for her urine HCG being positive and her UDM positive for amphetamine, methamphetamine, and THC. Collateral from her older sister states that she's been using substances on and off since she was 13 years old. Sister believes that AL has been having delusions and hearing voices even when she's not using substances. Sister does not live close by, and patient does not have a good support system. You decide to observe her. 20 hours later, she seems to have metabolized substances, and on reevaluation, she's no longer actively endorsing thoughts of wanting to hurt her baby or herself, but does continue to be somewhat disorganized in thought process. When you ask her about what she said of her child or being pregnant with a parasite, she says, yeah, it's taking all my nutrients. That's what a parasite does. If you could please use the QR code. You don't have to sign in, but if you could go ahead and answer this question, what is AL's disposition? All right, so everyone that has responded has said to admit her. Good call. Go ahead and turn that off. You decide to admit her. She's admitted to MHC and started on antipsychotics. She's discharged a week later with follow-up scheduled at the Milagro Clinic. For those of y'all who are unaware, the Milagro Clinic is run by family medicine. They take care of prenatal patients with comorbid substance use disorders. Perinatal psychiatry is co-located there for psychiatric care that's coordinated with their primary care. She attends her appointments, continues to take her medications, and achieves recovery from all substances. At 37 weeks gestation, she goes into labor and gives birth to a baby. They're both discharged after a few days from the hospital, and they have follow-up at Focus Clinic. Focus Clinic is a clinic run by family medicine and pediatrics that takes care of postpartum patients with either comorbid substance use or other high-risk diagnoses and their children. And perinatal psychiatry is co-located there as well. Let's look at what happens if we were to decide to discharge her. She's discharged from PES, and you send an ad hoc to notify the OB department of her pregnancy. She has lost the follow-up and does not receive any prenatal care. 6 months later, she presents to OB triage and delivers a baby at an estimated 36 weeks gestation. OB discharges her and places referral to perinatal psychiatry. She presents to clinic a week later and is floridly psychotic. She's talking about people who are spying on her, trying to kidnap her child, poisoning their water source. She and baby appear disheveled and malnourished. She has lost weight, and baby has lost over 10% of their birth weight. She is admitted to MHC, and because of a lack of social support, CYFD was contacted for baby. It's very difficult in these cases for the mother to regain custody of the child. Some considerations for pregnant patients in MHC. The causes of agitation are going to look the same as in non-pregnant patients. So exacerbation or onset of mental illness, medication or drug withdrawal, intoxication, delirium, medical illness. Regarding intoxication and withdrawal of substances, treat alcohol withdrawal with benzos, and you can use methadone and buprenorphine for opiate use disorder. I'm sorry, didn't realize that would do that. Okay. As far as dealing with agitation, always want to try verbal de-escalation first. If you're looking at PO medications, if you need an antipsychotic, use an antipsychotic that the patient is already taking. Otherwise, you can use Seroquel. Ativan, Benadryl, and hydroxyzine are fine. If you're looking at IM antipsychotics, you can use IM haloperidol. And again, Ativan and Benadryl are fine. When you're looking at restraining a pregnant patient, you want to make sure that they are restrained in the left lateral decubitus position. As you can see over here, when they are fully supine, the aorta and vena cava are compressed by the pregnancy, so it'll be better for blood flow for the patient and for the fetus to be in the left lateral decubitus position. When you're looking at admission comfort on the unit, the geriatric unit may be more appropriate or safe. Shifting to the postpartum time. This is also a high risk time. For women who have an existing mood disorder, relapse rate postpartum is 30% for unipolar depression and 52% for bipolar depression or manic episode. Anxiety disorders are diagnosed in almost 10% of women postpartum, and women with a psychiatric disorder are in the highest chance of being psychiatrically hospitalized in their first year of postpartum. Now let's look at a case of a patient postpartum with a potentially different disposition outcome. PA is a 32-year-old G1P1, assigned female at birth, uses they, them pronouns, 6 weeks postpartum, brought in by partner who's very concerned about baby's safety. On exam, the patient tells you that they are having constant thoughts of throwing their child out of the window on the second floor. Labs are noteworthy for a negative UDM. Collateral from the partner states that for the last several days, PA has been talking more frequently of throwing their child out of the window of their bedroom, where they are all currently sleeping. He's very worried that his partner might act on these thoughts, especially when he is asleep. We have another QR code if you want to go ahead and follow that one. Again, you can skip putting in your name, and if you could just write down some differential diagnoses that come to mind. These are really great. I'll give you all another like 30 seconds. I kind of forgot when 30 seconds was, so I'm going to just go ahead. So these are awesome responses. Thank you very much. Some of the responses include postpartum psychosis, depression with psychotic features, adjustment disorder, new onset schizophrenia, withdrawal from substances, bipolar, OCD, psychosis, intrusive thoughts in the context of OCD, postpartum OCD, postpartum psychosis, postpartum medical condition, depression. So I intentionally made this case very vague to demonstrate how nuanced these presentations can be. Those are really great responses. Thank you for that. So a patient with postpartum psychosis could present with some of the following thoughts. PA tells you that their child has special powers and can fly. They have periods where they do not know who their child is. They're frustrated that their partner does not believe them. So these are going to be in line with a postpartum psychosis kind of picture. Keep in mind that with postpartum psychosis, patients have lost reality testing. These thoughts are egosyntonic. As a reminder, this means that the thoughts that the patient is having are in line with the current values, behaviors, and goals. On the contrary, if someone tells you they're having thoughts like they're fearful they're going to injure their child, These thoughts are distressing to them, and they worry that these thoughts make them a bad parent. They're actively trying to prevent hurting the child by avoiding the windows on the second floor. These thoughts are more in line with postpartum OCD. While postpartum OCD is not considered a psychiatric emergency, the thoughts and concerns can present very similarly to psychosis, but they warrant a very different intervention. These can be really difficult to delineate. Expressing concern about baby safety as a provider when the patient is having intrusive thoughts or compulsive behaviors can be further stigmatizing to the patient and worsen their shame. This could result to a reluctance to pursue treatment in the future. Looking at these thoughts, these are all egosyntonic, meaning that they are in line with the patient's current values, behaviors, and goals. So looking a little bit more at postpartum psychosis, the incidence is 1 to 2 per 1,000 births. The greatest risk factors are personal or family history of a prior postpartum psychosis or bipolar disorder. Other risk factors include prematurity, advanced maternal age, occurrence of mood disorder during that pregnancy. However, most of these cases will occur in patients without a history of psychiatric symptoms. 50 to 80% of patients with postpartum psychosis will go on to develop symptoms consistent with bipolar disorder. The risk of infanticide related to untreated postpartum psychosis is 4%. Typically, the symptoms will onset 3 to 10 days after birth, but can occur up to a year postpartum. These symptoms will look very different from a psychosis due to a primary psychotic disorder or from substances. You'll see more disorganization, bizarre behaviors, non-auditory hallucinations, so tactile, visual. You would see grandiose, paranoid, or bizarre delusions. You can see altruistic delusions that the patient, when killing themselves or killing their infant, could save themselves or their infant from like a fate worse than death. Changes in cognition will include delirium-like confusion, derealization, disorientation. These symptoms can wax and wane, so it's really important to use collateral. Even if the patient does not seem to be dissociated from reality at the time, if you're hearing collateral that suggests otherwise, it's very important. Patients often have little to no insight into their symptoms. This is a description of a patient with postpartum psychosis that I think is really useful. So I'll just go ahead and read it. So patient with first onset postpartum psychosis with depressed features. The patient was a well-dressed and impeccably groomed professional woman who came to the clinic stating that she was, quote, depressed, but no one believes me. In response to a question about unusual experiences, she responded in a matter-of-fact manner. Inside me is a dark forest. If you saw me when it comes out, you would see a dark shadow that looks like me outside of me. It is black, but you can see through it and put your hand through it. The shadow takes over me and makes me do things. Yesterday, the shadow made me put a pillow over the baby's face, and I might have suffocated him if my toddler hadn't pulled my pant leg and alerted me to make the shadow go back inside. When I feel the shadow coming out, I walk outside on the porch with the baby and my daughter. If I kill myself, will the shadow go away? It's noteworthy that this incident occurred in January in the Midwest. So looking at postpartum obsessive compulsive disorder, the prevalence is 2 to 11%. However, intrusive thoughts of harmed baby are very common postpartum. Data from 3 prospective investigations of all healthy pregnant women found that all of the women who participated had at least one intrusive thought related to harming their baby in the first month postpartum. These typically resolve in the first few weeks. Risk factors include a personal psychiatric history, being in that early postpartum period in the first month, a previous diagnosis of postpartum OCD, prematurity, a personal history of depression, obsessive compulsive personality disorder, and avoidant personality disorder. Postpartum OCD has really high comorbidity rates with other diagnoses. So 27.5% of these patients will also have an anxiety disorder, and 70.6% of these patients will have a depressive disorder. Symptoms include obsessions, which are persistent, distressing, and impairing thoughts that may be accompanied by compulsive behaviors. Engaging in compulsive behaviors to an attempt to mitigate or relieve thoughts of distress. The obsessions and compulsions must be distressing to meet criteria for postpartum OCD. The obsessions are more frequent than the compulsions, and you do not require both for diagnosis. Here's a couple of examples. So one intrusive thought or obsession could be my child will stop breathing at night, or a concern about SIDS. This is a really common one. This could result in compulsive checking on the baby throughout the night and not having the mom get the proper sleep. So postpartum OCD is a really difficult diagnosis to make. OCD symptoms may not be recognized by the patient as being abnormal. The themes of these thoughts may seem to be appropriate with a newborn child. However, the frequency and severity of the thought results in significant distress and impairment. So if we were looking at our patient PA, many parents might be concerned about their child falling out of the window of a second floor. However, PA could be meeting criteria for postpartum OCD based on how distressing and impairing this thought is to them, and potentially the avoidance of all windows as a result. Another reason this diagnosis can be very difficult to make is that patients may have shame and guilt and not disclose these symptoms to their families or doctors. There can be a fear of being reported to CPS and losing custody of the child. It's very important as providers to ensure that we're not being judgmental, trying to normalize when appropriate, and reminding patients that bad thoughts don't make them bad parents. Questions to ask to elicit OCD symptoms include, do you have unpleasant thoughts, urges, or images that repeatedly enter your mind? Do you feel you have to do certain behaviors or mental acts over and over again to feel better? As I said, most birthing parents will experience intrusive thoughts that do not meet criteria for postpartum OCD. Some considerations for postpartum pregnancy in MHC. Agitation, medications are going to be agitation treatment is managed the same as pregnant patients. Using restraints in the supine position is fine. Again, the geriatric unit may be more appropriate. If a patient is chest feeding, they may need to pump or be able to chest feed and have scheduled observed time with the baby. You do require to have a one-on-one while pumping. The pump can either be brought from home or it can be ordered through the hospital. So then relative infant dose is the average amount of medication that is transferred in the breast milk. Whenever you start a medication, you want to make sure that the relative infant dose is less than 10%, which is considered safe for breastfeeding by the American Academy of Pediatrics. Most of our psychiatric medications are compatible with breastfeeding. So returning back to our patient PA and looking at disposition options. If we feel like she had a postpartum OCD diagnosis, these folks were typically able to discharge. You want to be aware of social support, sleep, make sure that the compulsions or checking behaviors are not putting the infant at risk. So an example of this could be that the checking behaviors are taking so long that the baby is not attended to. So postpartum OCD, you can typically discharge. However, for folks with postpartum psychosis, we typically need to hospitalize at least for a few days. You could consider discharge if the patient has adequate social support, you feel good about their medication compliance and follow-up, but you would need baby to be around family the whole time, and you would not want to leave patient alone with the baby. You'd also want to give them strict return precautions. Sometimes with postpartum psychosis, the patient can have delusions that are not related to the baby. So for example, the patient's worried, having paranoid delusions of neighbors spying on them. This could be also okay to discharge. However, if these delusions change to being about the baby, then you'd want to make sure that they would represent for reassessment and possible admission. Just as this is a thought, when you are considering a risk assessment, just because an individual is pregnant or has a baby does not mean that this is protective. So this just shows how to place a referral. It's under ad hoc, under the main tab. It's going to be towards the middle at the bottom. Fill out the yellow boxes and click this bottom journeys/perinatal psychiatry. And then again, fill out the yellow boxes and any other information. All right, so for the last part of this presentation, I'd like to shift the focus to safety concerns in this population. When we think of maternal death in America, we often think of medical causes as the etiology. However, recent studies show that the top causes are actually homicide and suicide. When we're looking at pregnancy-associated suicides, there's about 2 suicides per 100,000 live births. Half of these occur during pregnancy, and half of these occur in the year postpartum. Common risk factors include a history of depression, substance use disorder, and intimate partner violence, or IPV. 54.3% of pregnancy-associated suicides involved IPV that appeared to be related, contribute to the suicide. 16 to 23% of Americans experience IPV during pregnancy. It is 3 times more likely to experience IPV while pregnant compared to when not pregnant. Pregnancy-associated suicide has been found to be more common in white women compared to Black women. Pregnancy-associated homicides is the leading cause of all maternal mortality, including hypertension, hemorrhage, and infection by more than 2-fold when you look at this graph. The rates are 3.62 during pregnancy and up to a year postpartum, and 2.21% if restricted to only the first 42 days postpartum. 77% of the homicides occur during pregnancy, so much more common when pregnant compared to the postpartum period. Pregnancy was associated with a higher risk of homicide compared to reproductive age women who were not in the peripartum period. Also among females less than 24 years of age or over 40, and amongst Black females. When we're looking specifically at pregnancy-associated homicides of Black women, so outside the peripartum period, IPV rates have been found to be similar between Black and white populations. However, pregnant Black women are 8 times more likely to die from pregnancy-associated homicide compared to non-pregnant Black women. They are also 3 times more likely to die from pregnancy-associated homicide than white pregnant women. These differences can be explained by the following. Racial inequity in unintended pregnancies, which has been associated with intimate partner stress, conflict, and violence. Racism within maternity care settings that may prevent girls and women from disclosing victimization and otherwise impede access to services, resources, and support. Research has also identified multiple ways in which medical, law enforcement, criminal justice, child welfare, and other social service systems responding to violence victimization perpetuate the discriminatory treatment so that Black women and girls cannot or choose not to access services when needed, or that they are ineffective or inadequate when they do. When we are looking at IPV and peripartum homicide, there's a couple of factors that can intersect to worsen outcomes, and we'll be looking at each of these. Starting with gun laws. 7 of 10 homicides that occurred during the peripartum period involved a firearm. There's two types of laws that target IPV and gun ownership, but not all states have a mechanism of ensuring that the perpetrators relinquish their firearms, which could either be by the individual giving up their firearms voluntarily or having them removed by an external agency. These two types of laws are the restriction of possession of firearms by people who have been convicted of a domestic violence misdemeanor, and the restriction of possession of firearms to people who have domestic violence related restraining orders. So some types of restriction laws are effective. A study on policies at the state level found that state laws that prohibit the possession of firearms and require relinquishment from those with misdemeanors that were associated with IPV have a decrease in pregnancy-associated homicides. However, the laws that only target those with with the domestic violence restraining order does not lead to a statistically significant decrease in pregnancy-associated homicide. Again, these laws are only effective if coupled with a relinquishment law. Over here, you can see ACOG's statement of policy in gun violence and safety. Looking specifically at New Mexico, people convicted of specific domestic violence offenses, including battery against a household member, criminally stalking any person, regardless of the relationship, or any other misdemeanor crime of domestic violence, are prohibited from accessing firearms. People who have completed a sentence or period of probation for any felony cannot access firearms for 10 years. And for domestic violence protective orders, the court is responsible to determine whether or not the perpetrator needs to be barred from accessing firearms, and then a law enforcement officer can be directed to take possession of the firearms. There is something called the Extreme Risk Firearm Protection Order Act, which can temporarily restrict firearm access to individuals who are considered to be a risk to themselves or others. You'd have to file a petition and go to court, and this is not going to be significant for patients who are experiencing IPV. These laws in New Mexico do not prohibit people from accessing ammunition. They do not require people who are convicted of a domestic violence to provide proof that they did relinquish their firearms, and they do not require direct courts to issue search warrants for the removal of firearms. So basically, we cannot ensure their relinquishment. Looking at restricted access to abortion care. Unintended pregnancies are more likely to occur in violent relationships, and reproductive coercion is a form of IPV. Reproductive coercion can result in unintended pregnancies through rape, sexual assault, sabotaging contraception, and restricting women's contraception use through threats, violence, coercion, or control. Research prior to the overturning of Roe v. Wade showed that access to abortions is associated with a reduction in violence by the man involved with the pregnancy. States with more restriction to abortion access have higher rates of peripartum homicide. This map just shows the access after Roe v. Wade was overturned, with the purple-blue being most protective for abortion rights and orange being the least protective. Pregnancy-associated homicide is also higher in states where divorce cannot be finalized during pregnancy. Restrictions on divorcing while pregnant has to do with establishing paternity, child custody, and child support issues. By law, divorce cannot be finalized during pregnancy in Texas, Arkansas, and Missouri, as shown by the white dots. There are other states in which divorce is not finalized during pregnancy as a matter of practice, but not law. And that actually includes Arizona and like a state like California. So that's a lot of information. Any thoughts or feelings coming up for anybody that they'd like to share? Welcome to use the chat box as well. All right, well, if anything comes up, feel free to share. Oh, never mind. Dr. Olmsted says, feels pretty intrusive to not let folks get divorced while pregnant, assuming that doesn't take IPV into account. Unfortunately, in states like Arkansas, Missouri, and Texas, it can be relevant, but the vast majority of the times, these folks are not able to actually have the divorce finalized while pregnant. Thanks, Dr. Delmore. All right, so just a last, before I wrap things up, over the last month, there's been a lot of news on the restrictions on information available on federal websites and restrictions on new research. Some of the articles you may have seen include the following. Thankfully, more recently in the last few days, there have been calls to restore some of this information. So this is really concerning. If we can't use terms like Black and pregnant and women in research, then we will be severely limiting the amount of meaningful data that we can obtain regarding these populations, and therefore will not be able to provide effective care for these vulnerable populations. And that is all I have.
Thank you so much, Dr. Khalil, for that really thorough presentation. I think we can give everyone an opportunity to either raise their hand and ask questions or throw questions into the chat, and I'm happy to read on your behalf if you prefer. A lot of voice gratitude.
Thank you so much, Dr. Khalil. This has been really informational and really inspiring to hear about. I know it's a big ask, but I wonder if you can make any suggestions about how we, given this information, how we might best support our patients and their families, especially our pregnant patients.
Of course. So I'm assuming you're talking about the latter half of the. Okay, cool.
Either the first half or the latter half.
Okay.
I mean, either reminding us about clinical priorities and screening priorities, and then also during this turbulent time as well.
Of course. So I think the number one thing is the judgmental aspect. It's really difficult being pregnant, and people have different ways of being pregnant and being postpartum, and trying to appreciate that chances are they're trying to do the best for them and their child. Keeping that in mind with every interaction and encounter with these patients. As far as the firearms bit, I think it was really eye-opening to me because that's something I ask in every single PES encounter. However, if the person's like, yeah, I have firearms, but they're locked up and my partner has access to them, I typically consider that to be less concerning as far as a suicide risk. I hadn't ever considered what the risks were for homicide. And so the fact that there is a firearm associated in 77% of pregnancy associated homicides is really concerning. And I don't know that we necessarily in practice could do much different, but being mindful that that does put the patient at increased risk, especially if there's a history of IPV. And then as far as things to do during these turbulent times, I mean, that is a great question. And if I knew, I would probably feel a lot better. I'm sorry, I don't really have much on that other than speak up and speak out and contact your representatives if you feel comfortable doing so. Thanks, Dr. Delmore. So for women who have OCD and want to get pregnant, that's a great question. That is and this is actually for most mental health diagnoses, we typically do not recommend discontinuing medications either when you're planning to get pregnant or trying, or when you do get pregnant. So typically, when we look at OCD, we're looking at a treatment with SSRIs, and the vast majority of our SSRIs are safe in pregnancy. The ones that are a little less safe, when you look at the risk of the fetus being exposed to a patient with high rates of anxiety from OCD, you also have risks from that. So being able to have that conversation with the patient is really important.
Dr. Khalil, I'm kind of curious, thinking about the sensitive nature of patients coming to us in PES with psychiatric emergencies or mood and anxiety symptoms in the perinatal period, and you find that their partner has a firearm. I agree. I can't say that often I'm thinking about the risk of violence towards them, when obviously that is something we should consider. Do you have any thoughts on how you may frame that conversation with this patient to ensure to not cause any contention between partner and patient, or for the patient to feel like maybe you're not a trusted provider? Just curious how you may navigate that conversation.
It's a really great question. And I think it depends a lot on whether or not the patient has stated that there is a history of IPV in that relationship. If there is a history of IPV and the patient felt comfortable to disclose that to me, I would want to be cautionary. I would imagine that things like storing the bullets separately than the firearms and having locks and things like that would decrease the risk of homicide as well as suicide. Those might be some things I would suggest. If the patient has not endorsed a history of IPV, I don't know that I would necessarily bring this up, because it does seem like it could cause more harm to the patient-provider relationship. Dr. Mantrek said, some may want to have a lower threshold for involuntarily hospitalizing a pregnant person due to risk to the fetus. This runs up against politicized debates about fetal personhood. Can harm to fetus be considered harm to other or self? And is there any case law on whether harm to fetus can be considered in an involuntary hospitalization? Great question, Dr. Mantrek. I am not sure if there's any case law about that. My thought is that if a patient comes in with a planned and wanted pregnancy initially, but then due to their psychiatric illness is exhibiting things that may put them or the fetus at higher risk, I would consider that to be a lower threshold for hospitalization. However, if this person is not wanting the pregnancy, or it's an unplanned pregnancy, and they're doing things like, I don't know, that could be considered unsafe to them or the fetus, I would not necessarily want to lower my threshold for that. Otherwise, we would be hospitalizing a lot of women who choose to use alcohol or cannabis or tobacco during pregnancy. I think this is a really slippery slope, because our number one priority should always be to the woman. That is our patient. And if her priority is the fetus, then that is also our priority. Dr. Price?
Hi, Dr. Khalil. What a fantastic presentation. Thank you so much. I'm curious if you could talk to, I've found this idea of distinguishing between sort of a more subtle postpartum psychosis and a more severe postpartum OCD a little bit difficult, particularly when the psychosis is distressing to the patient. The thoughts that they're having are distressing, and it sort of can really play with my medical decision making in terms of whether it's ego syntonic or not. And so can you just speak to sort of how you approach that when psychosis is distressing to a patient?
Yeah, of course. And that's a really great question. And I think it is really difficult, and we're not always going to be correct. Thanks, Dr. Rose, for sharing that. If you would like to share more information, you're welcome to, but no pressure at all. I think that when we're looking at a patient who we're not sure if we're looking at postpartum OCD or postpartum psychosis, and their psychosis is distressing to them, I would say that with the psychosis, if they are distressed enough that they would be okay with a voluntary admission, that's something to consider regardless. As far as the differentiation between the OCD and the psychosis, I found that although the psychotic symptoms can be distressing, they're not necessarily distressing in the same way as the OCD symptoms are. So if I'm concerned about cutting my child with a knife while I'm cutting vegetables, and it looks like it's more of an OCD picture, right? I'm going to do things to mitigate that risk. I'm going to try to hide knives away. I'm going to try to restrict my access. I'm going to be like, you know what? No one's eating vegetables anymore, whatever it is. Versus with a psychotic patient, they're not necessarily going to have those behaviors to try to decrease the harm. As always, if you're unsure, admission, OBS, not a bad idea. I hope that's helpful.
And if I may add, I also find that often intrusive thoughts are accompanied by some other psychotic symptom when a patient is presented with postpartum psychosis. So I think it would be unusual for them to have this isolated intrusive thought and no other psychotic symptoms if they were experiencing postpartum psychosis. Any other questions?
Happy to answer questions after this as well, if you think of something.
Thank you again so much, Dr. Khalil, and to the whole department for joining us for this presentation.
Thank you very much. Have a wonderful weekend.